growing, and it's coming up to the surface. So they look a little bit younger than you would anticipate. But that's why they get the hair loss, all the rapid growing structures. That's why their GI tract sloughs and they get blood in their stool, because those are rapidly growing cells that get replaced frequently. That all sloughs off. They get nauseated from it. Some of that's from the sloughing, some is from the effect on the brain. You know, and the weakness is part of it. It suppresses their body's immune system. It takes about 4 or 5 days. That's when they tend to get an infection. You'll see them, and that's when they have their fevers or they're infected. Their white count's really low, and they're you know, susceptible to just about anything. So yeah, the weakness is part of how the drug works. Okay, we mentioned dehydration, and they just give you some examples of different types: isotonic, hypernatremic, hyponatremic, and what that means. Again, you can't diagnose this from looking at a patient. These are based on electrolytes. Overhydration. No, it's actually, you don't see this except in SIADH, and that you would have to know that, because you may not notice it. They might be edematous, okay, but you would not necessarily know that's what it's from. Well, you have an inappropriate secretion of antidiuretic hormone, meaning you have too much of it, you hang on to all your water and dilute your sodium. But that's not something that you would, if you saw a patient with it, you just assume they were edematous for some other reason, unless they told you that they did that. But most of these people, the only way you would know is if they said, I drink 10 gallons of water a day. Well, then you know it's iatrogenic, meaning that they did it to themselves, and that's why they're edematous, because they overloaded themselves with fluid. Does that happen? Not in the normal population most of the time. I have seen it in the psych population. Some people think they got to drink a lot of water, flushes their system, but you know, most of them are a little wacky in the brain. So they tend to overdo it, and it does cause cerebral edema and all that kind of thing. Sodium, potassium, okay. I knew that this was here. I thought it was up in the other slides, but. So we're talking about electrolytes. We talked about sodium a little bit, chlorides minimally, because we don't really need to discuss that at length. Let's talk about potassium, because you can see potassium issues in what? What do you do in the field that tells you a patient has a potassium problem or may have a potassium problem? Okay, so you can see it on an EKG. In addition, like sodium, it can make the patient feel weak. So if you get a call for a patient who's weak and dizzy and can't stand up, and you go to their house, what are you going to look for in terms of their meds? We said it earlier. You're going to look for diuretics. Okay, you're going to look for the diuretics. And this is one of the times that you can actually make a diagnosis without having to do a lab test. We know it's needed for normal neurologic functions, muscle contraction, glycogen storage. That has to deal with the sugar storage and manufacture in the liver. Skeletal muscle needs it, again, for contraction purposes. So yes, it is needed for normal neurologic functions, as is sodium and calcium. Having said calcium, we see that, again, we need this for muscle contraction, nerve impulse transmission, helps stabilize the cell membrane. So, does this affect heart rate? Does this affect cardiac contractility? Yeah, of course it does. That's how calcium channel blockers work. Can you see hyper or hypocalcemia on an EKG? What does it usually look like? Okay, so you have a change in the QRS. Do we carry calcium? No. And actually, in this day and age, we should. Why should we carry calcium? They're very commonly used, and we're seeing a lot more toxicities from them. People taking multiple doses. Remember, I talked about a case I had years ago at Collier Regional where a guy came in and had doubled all his meds because he didn't know that he was supposed to stop the old meds and just take the new ones, so he was taking them both. And he was doubling his doses of calcium channel blockers and of beta blockers. And he came in with a pacemaker, intubated, with a heart rate of 10. And I said to the medics, well, what are his meds? And they showed me his meds, and I gave him the usual that I give for these drugs. And his heart rate came up. We took the pacer off him. He woke up, tried to pull the tube out. So we extubated him, and I started talking to him, and he said, well, he said, I just got out of the hospital. And I said, for what? He said, oh, I had a rhythm problem. He said, and it was, I think he had AFib. I don't remember exactly. And he said, so they put me on more medication. And I said, so what are you taking? Well, I'm taking all these meds that I had before I went into the hospital, and I'm taking all these new meds. And of course, they're almost the same thing. So he's taking double the dose, and that explained what happened to him. Magnesium. Where do you see magnesium being used in the field? What kind of rhythm problem? Okay. One common drug lowers magnesium levels. And it's probably one of the more common drugs that people take. That's it, omeprazole. So you see a patient on omeprazole that has weird looking rhythm on their EKG, then you got to think of their magnesium being low. Not that you can treat it, but it's something to think about. Acid base. This is always a difficult topic for people to grasp when they have blood gases that they need to look at and make a determination. It's not so difficult if you do it from a disease process. Okay, so they talk about the hydrogen ion either being a donor in an acid or an acceptor in a base solution, and the balance from 0 to 14. For our purposes, blood gases go for a normal of 7.35 to 7.45. That's considered normal. Below 7.35 is acidotic, above 7.45 is alkalotic. We don't measure blood gases. So what do we look at to know if a patient's acidotic or alkalotic? Okay, we look at their capnography, and it gives us an idea. Now, is that capnography going to tell us if it's metabolic? No, but it gives us an idea if it's respiratory. In addition, what helps us when we look at a patient and we're making a clinical assumption about their diagnosis? Does your knowledge of what that clinical diagnosis is help you determine if they're acidotic or alkalotic? If I told you that patient's a diabetic and you did their sugar and it was 500, what would that tell you about their acid-base status? Okay, they're probably acidotic. So yeah, you can tell if a patient's acidotic or alkalotic. You have a patient in CHF that's in extremis and you need to bag them or ventilate them, what kind of acid-base disturbance do they have, acidotic or alkalotic? They're going to be acidotic. So remember, when you see these disease processes and acute exacerbation, even in sepsis, these patients are going to be acidotic. You don't need a pH to know that. It's the disease process itself is going to cause that. Why did they take bicarb out of the equation in ACLS? Well, there were some studies done 20 years ago that suggested too much bicarb created an alkalosis that the patient couldn't tolerate because the patient and the human body responds better in a slightly acidotic realm than it does in an alkalotic realm. So they stopped using bicarb. Do we have a need for bicarb today? Sure we do. I use it in the ER all the time.
Is there any disease process that we see would be alkalotic?
Not usually.
Maybe the only one, maybe?
What?
Toxin, yeah.
No.
What we did to,
Alkalosis, the most common causes of alkalosis are iatrogenic. meaning we did it. So I can't think of anything offhand that would present as alkalosis. You can get a hyperchloremic alkalosis from giving patients too much salt water. So in that situation, you can get them where they're alkalotic, but that's kind of rare.
But basically for us, I mean, it's always going to be
It's almost always going to be acidotic. You're very rarely going to have an alkalotic patient.
bagging or taking care of their airways.
Yeah, remember the two main mechanisms, respiratory and kidneys, okay? Respiratory is fast and incomplete, kidneys is slow and complete. You get better buffering through the kidneys, but it doesn't work that fast. So what I'm saying to you is for our purposes in the street, everybody's acidotic. It's the simplest way to do it. And you won't be wrong. Again, we can deal with some of the chemistry. I don't really think that you need to deal with that. You don't need to know it per se because we don't utilize it at all. We understand the disease processes cause acidosis. There are buffer systems in the body. We talk about them a little bit when we say how the kidneys and the lungs attempt to return the pH to normal. These are other mechanisms that do also involve the kidneys or the lungs. Again, not necessary. So this chemistry equation up there under the cell wall, memorize that. We're going to utilize that every time we see a patient who we think is acidotic and is using protein buffering. Here's metabolic alkalosis. Again, more chemistry. Here's metabolic alkalosis. So you can see that these little algorithms are all nice and neat and useless. Normally, and this is important because this isn't the standard in the hospital, but normally pre-hospital wise, you're not going to see a whole lot of mixed acid-base disturbances because you're going to usually see the patient in extremis. What this means, mixed acid-base disturbances, is a patient who has a problem, tries to compensate for it, maybe doesn't compensate completely, and when you look at their blood gas, you get numbers that at first you're not sure what they mean because they don't match up to what you're thinking is going on, and that means that they've just had a partially compensated correction of their acidosis. Okay? Again, you're not going to see that. We don't look at blood gases. Do we need to look at them? No, not really. Now, if this were a disaster and you were the only medical care around for 100 miles and you had to keep these patients for 5, 6, 8 hours, well then you would need something like that because you would need to have a better idea what's going on, especially once you initiate treatment. This is a basic tenet for acid-base disturbances, and if you were to be able to measure the blood gases, you would see this kind of reaction. But just to keep in the back of your head, when you have a metabolic acidosis, what's going to happen to your respirations? They're going to increase. You're going to blow off that CO2, okay, trying to get that pH, to come back up. If you have a patient who is acidotic, they're hypoventilatory, they're not ventilating, they're not breathing, the body's going to attempt to address it metabolically. It's one of the compensatory mechanisms. We don't need this. We don't need this. Well, I'll just mention this briefly. We don't really do this in the field, but we do see patients who are at risk for certain kinds of situations, certain kinds of medical diseases. For instance, what are smokers at risk for? Okay, they have lung cancer, emphysema, frequent COPD, frequent infections, okay, throat cancer, inanition, they get cachectic, they don't eat. So that's what this is talking about. How about patients at risk for heart disease? What do they usually have as an underlying issue, or things that they have as an underlying issue? Hypertension, hyperlipidemia, smoking, they don't exercise, So these are things that put them at risk to have a problem down the road. Under Obamacare, you'll be penalized for not taking care of yourself because you cost the system more money by your lifestyle. So that is, within 10 years, that will factor into your premiums and everything. So those that are overweight and don't manage themselves and eat and drink and basically don't care will have much higher premiums than the people who do try to make a difference in their life. And they'll also have limited care. That'll be another aspect of it that will be coming. Alzheimer's, degenerative neurologic diseases, we don't know a lot about them. We think we know about them, but we don't know as much as we really need to know because we haven't been able to make much of a change in them. There are a few studies that are anecdotal out there, one of them in particular by a Dr. Sears, who has experimented with high-dose omega-3s in brain injury patients. And his last case was one of his most dramatic. He had an 18-year-old that was hit by a car, was told by the trauma doctors and the neurosurgeons that he was never going to walk or talk again. They weren't sure he'd even survive. They felt that his brain activity was minimal and that he was probably going to die. And the family had heard about this doctor who used high-dose omega-3s, and I'm talking about the capsules. I'm not talking anything IV. And they talked to him and they said to the doctors, we want our son to get these omega-3s. So the doctors are like, what the hell, we don't have anything to lose here, he's going to die. And they gave him, according to the doctor that recommended it, 20 grams of omega-3s a day. 20 grams. In 3 days, a guy opened up his eyes and was awake. In a week, he was talking. 3 months later, he was walking, and he was supposed to be dead. So the guy has used these omega-3s in about 18 cases and has had very good results, not all of them, but the majority of them have improved. But there's no double-blinded studies yet. You can buy omega-3s anywhere. So there's no money in it. So there's not going to be any studies done on it because there's no money in it. No drug company has a patent on omega-3s, so they're not going to do any studies with it. It's going to be all anecdotal kind of stuff. However, there are some people that are now trying it with Alzheimer's patients with progressive neurologic diseases and having pretty good results. There's a doctor in Naples, Dr. David Perlmutter. He's a neurologist. I think he trained at Columbia University in New York. I've listened to him speak. He's an amazing guy, thinks outside the box. He's had great results with patients with neurologic diseases using things that aren't standard, including omega-3s, gluten-free diets. There's a lot of things that he does that, are really cutting edge, but are not mainstream medicine. And so, of course, the traditional physicians are going to say, because that's what they do. If they don't understand something, they poo-poo it and say, oh, it doesn't work, it's garbage. Immunologic disorders, cancer. Now, these are just some of the risk factors for all of us. Okay. This is something you do see. This is something that in the field you can diagnose. This is something that does cause acidosis and eventually death at the cellular level, not just the organism level. So we know that hypoperfusion does what? It causes a decrease in oxygenation of the tissue by what? How does it do that? Well, yeah, you're not circulating the blood because you're not perfusing the tissue, so they're not getting the oxygen and you're not removing the CO2, okay? And that is really what the Fick principle is talking about. You've all had that at school, but you forget that that's the term for it. But that's what it's talking about, that principle of basic physiology of fluid and oxygenation. We've talked about this a lot. We talk about how decreased cardiac output changes those fluid shifts, decreases oxygenation of tissue, especially peripheral. You can have those fluid spaces filled up and lose intravascular volume because the fluid's not where it needs to be. Okay? Think about patients in stage 4 cardiogenic shock. They're in heart failure. You need to get rid of that fluid, but their problem is that their volume contracted intravascularly. So how do you treat those people? You give them fluid, does it make them worse? You give them pressors, does it make them worse or better? How do you treat them? We talk about shock, cardiogenic, just mentioned it, hypovolemic, neurogenic. So cardiogenic, bad MI, okay? What type of shock is an example of a hypovolemic shock? What kind of medical? Trauma. Okay, trauma. Also think of sepsis. That frequently is hypovolemic. We talked briefly, most of you guys are gone, about this new thing in the hospital Greg had brought up. He had gone to a lecture. They call it sepsis alert. And there are certain parameters patients are supposed to meet in order to call a sepsis alert. You know, it's like a trauma alert, a stroke alert, a cardiac alert. And as I said to Greg and the couple of guys that were here, you know I'm cynical, and so you understand that in a hospital they call a sepsis alert not because it brings anybody extra to you, or it makes x-ray work faster, or the lab work faster, or the nurses work faster. No, they call a sepsis alert because it improves their reimbursement for that patient. That's all it does. The rest of it doesn't change.
Is that how you're coding for billing?
Yes. You understand, most of the stuff that they do is purely a billing thing, because Medicare and CMS has you jump through all these little hoops because they don't want to pay you, so you look for reasons not to pay you. But if you look hard enough, there's other things in there that will make up the difference in pay, and that's what they have people that do that, a whole department in a hospital. They have 5 or 6 people. All their job is to go through the CMS changes that come out every so many months that are not announced to anybody and see what changes they need to make and what they do, and they come up with clinical parameters to incorporate those changes into the treatment of the patients. It's just ridiculous. So, neurogenic shock, the last one. Okay, again, can be spinal trauma. So again, trauma. Can be spinal cord infarction. You know, there are some things that can do that. Anaphylactic, septic, when we talked about sepsis, septic shock is really hypovolemic shock because they're almost always volume depleted and contracted because they're usually febrile, so they get dehydrated. And if you want to know how much water they lose from a fever, you can go to the Washington manual. You can get it online, and it gives you the calculation to do based upon their electrolytes and their BUN and creatinine. We don't have any of those. When you're in the field, you got your eyes, your nose, your ears, your hands, your mouth. That's all you got. And you got to use your own faculties and make a determination of what's going on with that patient. Anaphylactic shock. I don't know if we see this as much. There was a big debate last year at the Dallas conference of Eagles about the use of epi. And I saw that, didn't EMS just change the epi dose from 0.3 to 0.5? There was a big debate about that at the conference, and it was not unanimous. So I don't know why they changed the dose, because the conference, one guy insisted 0.3 was plenty, another guy said, well, you know, if the studies are suggesting maybe we should be doing 0.5. Anyway, just so you're aware, that's where that came from. You can research it online if you want, but the last time I looked at it, there was not a consensus that 0.5 was any better.
Are we changing? Yes.
Protocols changed. 0.5 IM. They actually recommended IM over sub-Q. So now, if you give 0.3 IM, am I going to come down and give you shit? No, I'm not. Let me think of if you would see this. Most of the time when we get to this kind of physiologic disease process, these are people that have been sick and in the hospital. You don't normally see this. When you get these people, you have their first and primary illness as they start to go through the process of degeneration and the cellular injury, so you're seeing them in the very beginning. You don't normally see somebody that already has multiple organ system failure. This is the wonder of modern medicine, because we're treating all this stuff and the patients are dying and getting worse. Maybe we don't quite understand the physiology of what's going on. So you're not going to see this. I can't think of where you would find this. Maybe in a patient who is a hospice patient and family decides at the last moment they're not DNR, but I mean, usually those patients are going to die regardless. So I don't think you would ever see something like that. It's fine to know that it exists. That's okay. I don't know if we really need to talk about this. We know about our barriers that we have. The skin is a great barrier against most things that we come in contact with. Sometimes not chemicals per se, but most other things. You don't see it anymore, but organophosphate poisoning used to be a very prevalent kind of toxicity that we saw in farming communities because of the use of chemicals for bug control. Malathion was a big one. What's the other one? Dionysus, I can't remember the name of it. But it was also a similar chemical, and what it did is it caused, in humans, it caused profound pulmonary edema, and the treatment was atropine. The problem was that no hospital carried enough atropine for these patients. They would routinely require 5 to 10 milligrams of atropine. Most hospitals have a couple milligrams. On your rig, how much atropine do you have? That wouldn't be enough for a patient with organophosphate poisoning.
Carry a little in the hazmat, but when they expire,
Yeah.
you know, 'cause that's the most common thing.
Yeah. So that's the treatment. I used to see this many years ago in southern New Jersey because it's a farming area, and I would see this frequently, and guys that would forget they'd have a bottle of Malathion in the barn, and they'd decide, well, I'm going to spray this, and they'd pour it into a sprayer machine, and they'd get it on their hands, and they'd be spraying around without their mask and nothing covering their arms, and within 30 minutes they're coughing and hacking and having trouble breathing, and they come in and fulminant pulmonary edema. The biggest problem we would have with them is that many times, the EMS up there was volunteers, many times EMS and even the nurses in the ER wouldn't protect themselves and would get poisoned by touching the patients because it's excreted through their skin surface too. And now you not only have the patient that's having a problem, now your staff is having a problem. And you certainly don't have enough atropine for everybody. So frequently these patients need to be intubated fairly rapidly. Well, you don't need to know that. This gets very confusing. You don't need to know that. Again, this becomes really complex. I'm going to just mention this a little bit because this really is what we see with anaphylaxis. I mean, yes, you see it with other inflammatory diseases, but let's think about anaphylaxis for a minute. And I've mentioned these before, that you have this synthesis of leukotrienes, prostaglandins, vasoactive amines, chemiotactic factors. I mentioned this before. That's the immediate response. Mast cell destabilization for an acute inflammatory response. And our treatment is aimed at trying to address some of these issues with the medications that we use. So, we use steroids to try to stabilize mast cells, to help with that excretion of leukotrienes and those amines, those vasoactive amines. Vasoactive amines cause what? They cause vasoconstriction, okay? So we use the medications at our disposal, which are limited to steroids, epinephrine, antihistamines, and H2 blockers, which is your Pepcid and Zantac and Tagamet. Complement system, very confusing, that you will never use in the field. Don't need to know that. Don't really need to know that. It's not going to help you in your treatment. I mentioned this before, but I talk about healing, wound healing, and the reason we suture wounds is because it causes it to heal by primary intention, meaning that the edges grow together. Secondary intention is when it's open and it heals from the bottom up. So that's why we suture wounds. The only reason we